Number 1. Charles Cullen, a registered nurse whose murderous career across multiple medical facilities in New Jersey and Pennsylvania remains one of the most baffling and devastating chapters in the history of American healthcare, a case that exposed catastrophic failures in hospital administration and background checking systems. Born on February 22, 1960, in West Orange, New Jersey, Cullen experienced a deeply traumatic childhood marked by the suicide of his father when Charles was just an infant, followed by a highly dysfunctional upbringing under an emotionally distant and frequently cruel mother who often subjected him to psychological abuse and forced him to endure harsh physical punishments. Seeking an escape from his turbulent home life, Cullen enlisted in the United States Navy in 1977, where he served aboard the USS Woodrow Wilson as a petty officer 3rd class, though his time in the military was marred by frequent emotional breakdowns, self-harm incidents including the ingestion of toxic chemicals, and stints in psychiatric wards, ultimately leading to his medical discharge in 1984. Following his departure from the Navy, Cullen enrolled in nursing school at Mountainside Hospital School of Nursing in Montclair, New Jersey, graduating in 1986 and beginning what would become a nearly 2-decade-long descent into serial murder disguised as a noble medical profession. Cullen's first known victim was a judge named John Yengo Sr., who died at St. Barnabas Medical Center in Livingston, New Jersey, in 1988 under Cullen's care, though the death was not initially suspected to be foul play because Cullen used the intravenous medication digoxin, a heart drug that in massive doses causes fatal cardiac arrhythmias but is exceedingly difficult to detect in standard autopsies because it metabolizes quickly and mimics natural heart failure. Over the next 16 years, Cullen moved from hospital to hospital across New Jersey and Pennsylvania, including stints at Warren Hospital, Hunterdon Medical Center, Morristown Memorial Hospital, Liberty Nursing and Rehabilitation Center, Easton Hospital, and Lehigh Valley Hospital, typically leaving each institution only after being confronted about suspicious behavior, missing medication, or inexplicable patient deaths, yet incredibly, no hospital ever reported him to law enforcement or the State Nursing Board, choosing instead to allow him to resign quietly to avoid potential lawsuits and public relations disasters. Cullen's method of killing evolved over time but primarily involved administering lethal overdoses of digoxin, insulin, epinephrine, and other medications that would cause patients to go into fatal cardiac arrest or suffer irreversible brain damage from severe hypoglycemia, and he frequently targeted patients who were elderly, critically ill, or otherwise vulnerable, though he also killed non-terminal patients, including a young man recovering from a motorcycle accident and a relatively healthy patient admitted for a minor procedure. The investigation into Cullen's crimes finally began to crystallize in 2003 when colleagues at Somerset Medical Center in Somerville, New Jersey, noticed a disturbing pattern of patients dying during or immediately after Cullen's shifts, particularly in the critical care unit where non-fatal digoxin overdoses were being detected in patients who had no medical reason to be receiving the drug, prompting the hospital to quietly conduct an internal review while simultaneously working with the Somerset County Prosecutor's Office to build a case. Detectives Danny Baldwin and Tim Braun were assigned to the investigation and soon discovered that Cullen had been accessing the hospital's computerized medication dispensing system, known as a Pyxis machine, to withdraw medications for patients who had not been prescribed those drugs, creating a clear paper trail of his lethal activities. And when they confronted Cullen in December 2003 after tracing the tampered medication vials directly to his shifts, he initially denied any wrongdoing but eventually began confessing, leading investigators down a dark and sprawling path as he admitted to killing patients at virtually every facility where he had worked. During an exhaustive series of interrogations, Cullen confessed to killing approximately 40 patients, though authorities and medical experts who analyzed death records, patient charts, and medication logs across 9 different hospitals believe the actual number of victims could easily exceed 100 or even closer to 400, making him potentially the most prolific serial killer in American history, a chilling reality compounded by the fact that many of his victims were cremated before any suspicion was raised, meaning the physical evidence of his crimes was literally turned to ash. Cullen's legal proceedings were extraordinarily complex because of the sheer volume of jurisdictions involved and the challenge of proving his guilt in cases where bodies had been buried or cremated years earlier without toxicological evidence, leading prosecutors in multiple counties to pursue a coordinated plea agreement to avoid a series of protracted trials while ensuring that Cullen would never see the outside of a prison cell again. On April 29, 2004, Cullen pleaded guilty in a New Jersey courtroom to 13 murders and 2 attempted murders as part of a comprehensive plea deal that required him to cooperate fully with investigators in exchange for sparing him the death penalty, and he subsequently pleaded guilty to an additional 6 murders in Pennsylvania, receiving multiple consecutive life sentences with no possibility of parole, a sentence that ensures he will die behind bars. The broader implications of the Charles Cullen case sent shockwaves through the healthcare industry and led to intense scrutiny of the systems that allowed a serial killer to operate with impunity across so many institutions for so many years, revealing a deeply flawed culture within hospital administration that prioritized institutional reputation over patient safety and allowed a predatory nurse to simply resign and move to the next unsuspecting facility whenever questions were raised about his conduct. In the aftermath of the case, New Jersey and several other states passed what became known as the Cullen Law, which required healthcare facilities to report suspicious employee behavior and adverse patient events to state authorities and created a centralized database to track disciplinary actions and employment history for nurses and other medical professionals, closing the loopholes that Cullen had exploited for 16 years. Today, Charles Cullen is incarcerated at New Jersey State Prison in Trenton, serving his consecutive life sentences, and his case continues to be studied by criminologists, healthcare administrators, and legal scholars as the definitive example of institutional failure enabling serial murder, while the families of his victims continue to grapple with the agonizing knowledge that their loved ones did not die natural deaths but were deliberately murdered by the very person entrusted with their care, a profound betrayal of the most fundamental covenant in medicine. The impact on the communities and families affected by Cullen's reign of terror cannot be overstated, as hundreds of relatives were forced to exhume the memories of their loved ones' final days and confront the horrifying possibility that what they believed were peaceful, natural deaths were actually orchestrated acts of lethal violence perpetrated by a trusted caregiver, leaving scars that have never fully healed and fundamentally altering the way society views the vulnerability of patients in medical settings. Number 2. Genene Jones, a pediatric nurse whose deadly actions in a neonatal intensive care unit and pediatric ward in Texas during the late 1970s and early 1980s represent one of the most chilling examples of medical serial murder driven by a pathological need for attention and the desire to create medical emergencies that she could then dramatically resolve. Born Genene Jones on July 13, 1950, in San Antonio, Texas, she was given up for adoption as an infant and raised by a financially comfortable but emotionally distant family, and those who knew her in adulthood frequently described her as manipulative, attention-seeking, and prone to fabricating elaborate stories about her life and accomplishments, personality traits that would later prove to be red flags of a deeply disturbed individual capable of extraordinary deception. Jones began her nursing career after attending nursing school and eventually secured a position at Behar County Medical Center Hospital in San Antonio in the late 1970s, where she was assigned to the Pediatric Intensive Care Unit, a high-pressure environment where critically ill children required constant monitoring and specialized medical intervention. And it was within this ward that a disturbing pattern of unexplained emergencies and sudden deaths among infants and young children began to emerge. Between 1977 and 1981, an alarming number of pediatric patients at Behar County Medical Center experienced sudden, catastrophic deterioration, including severe breathing difficulties, cardiac arrest, and seizures, often occurring when Jones was the nurse on duty, and these incidents frequently happened during shifts where Jones was the only medical professional present in the immediate area, allowing her to control the narrative of what had happened to each child. Jones's modus operandi involved injecting her young patients with powerful medications that induced life-threatening medical crises, primarily succinylcholine, a paralytic drug that stops a patient's breathing by paralyzing the diaphragm and other respiratory muscles, and heparin, a blood thinner that can cause fatal internal bleeding, and in some cases, she administered these drugs in doses far exceeding any therapeutic range, essentially guaranteeing a near-fatal or fatal outcome for the tiny, vulnerable patients in her care. The motivation behind Jones's lethal injections was not financial gain or mercy killing but rather a deeply twisted psychological need to be perceived as a heroic lifesaver, as she would inject a child with a paralytic or other dangerous drug, wait for the child to go into respiratory or cardiac arrest, and then frantically call for doctors and other nurses to join her in performing dramatic resuscitation efforts, positioning herself as the tireless, skilled nurse fighting desperately to save a dying child, when in reality she was the one who had pushed the child to the brink of death in the first place. The death toll at Behar County Medical Center mounted steadily, with estimates ranging from as few as 11 to as many as 40 or more infant and child deaths attributed to Jones during her tenure there, though the exact number remains unknown because many of the deaths occurred in critically ill children whose underlying conditions provided plausible medical cover for their sudden deterioration, making it exceedingly difficult for physicians to distinguish between natural disease progression and deliberate medical sabotage. Concerns about the unusually high death rate in the pediatric unit eventually led hospital administrators to quietly close the pediatric intensive care unit in 1981 and transfer Jones to an outpatient pediatric clinic at a different location, a decision that prioritized avoiding scandal over holding a potentially murderous nurse accountable. And this failure to investigate or report Jones to law enforcement allowed her to continue working with children and ultimately cost more lives. After being transferred to the Kerrville Pediatric Clinic in Kerrville, Texas, Jones continued her deadly pattern, and on September 17, 1981, a 15-month-old girl named Chelsea McClellan was brought to the clinic for a routine checkup and immunization, but shortly after Jones administered an injection to the toddler, Chelsea went into severe respiratory distress and suffered a massive cardiac arrest, dying despite frantic resuscitation efforts by clinic staff and emergency responders. The death of Chelsea McClellan proved to be the turning point in the case, as the attending physician at the clinic, Dr. Kathleen Holland, became deeply suspicious of Jones's role in the toddler's death and began carefully reviewing other recent patient deaths and emergencies at the clinic, discovering a disturbing pattern of children experiencing severe reactions immediately after receiving injections from Jones, reactions that were inconsistent with the medications that were supposedly being administered. Dr. Holland's investigation led her to confront hospital administrators and eventually law enforcement, and when authorities examined the clinic's medication supplies and records, they found evidence that succinylcholine and other dangerous drugs had been tampered with or were missing, providing the first concrete physical evidence linking Jones to the suspicious medical emergencies. A formal criminal investigation was launched, and when Jones's residence was searched, investigators discovered medication vials and syringes that connected her directly to the drugs used to harm the children, and they also uncovered evidence that Jones had been stockpiling dangerous medications and removing them from medical facilities without authorization. The trial of Genene Jones for the murder of Chelsea McClellan began in 1984 in a Hill Country courthouse in Kerrville, Texas, and the prosecution presented a compelling case built on medical evidence, expert testimony about the pharmacological effects of the drugs found in Jones's possession, and the testimony of Dr. Holland and other medical professionals who detailed the suspicious pattern of emergencies that followed Jones's administration of injections to pediatric patients. The defense attempted to argue that the deaths and medical emergencies were the result of natural causes, contaminated medication batches, or medical incompetence on the part of the clinic's physicians, but the jury found the evidence overwhelmingly pointed to deliberate, malicious action by Jones, and on February 11, 1984, she was convicted of murder and sentenced to 99 years in prison, with an additional 60 years for injury to a child in a separate case involving another toddler who survived one of Jones's injection attacks. The broader implications of the Genene Jones case exposed the devastating consequences of failing to properly investigate and report suspicious medical professionals, as it was revealed that multiple doctors and nurses at Behar County Medical Center had expressed concerns about the death rate on Jones's watch years before Chelsea McClellan was murdered. Yet those concerns were suppressed or ignored by administrators who chose to protect the hospital's reputation rather than protect vulnerable patients. Perhaps the most outrageous chapter in the Jones saga came decades later when it was revealed that due to a peculiar Texas law at the time of her sentencing, which mandated automatic release of inmates to relieve prison overcrowding if their good behavior credits reduced their sentence to a certain threshold, Jones was scheduled to be released in 2018 after serving only about a third of her original sentence. A prospect that horrified the families of her victims and led to a frantic legislative effort to keep her behind bars. In response to the public outcry, Texas lawmakers passed emergency legislation specifically designed to prevent Jones's release, and several additional indictments were brought against her for other murders at Behar County Medical Center that had never been formally prosecuted, ensuring that she would face new trials and additional prison time rather than walking free. In 2018, Jones pleaded guilty to the murder of 11-month-old Joshua Sawyer, one of the infants who died under her care at Behar County Medical Center in 1981, and received an additional life sentence, effectively ensuring that she will remain incarcerated for the rest of her natural life. Today, Genene Jones remains imprisoned in Texas, and her case stands as a harrowing example of how a single individual exploiting the trust placed in medical professionals can cause devastation on an almost incomprehensible scale, leaving behind a legacy of grief for the families who lost their children and a permanent scar on the medical community's understanding of the threat posed by healthcare serial killers operating within their own institutions. Number 3, Donald Harvey, a former nurse's aide and orderly who operated in hospitals and nursing homes across Ohio and Kentucky for nearly 2 decades, earning the chilling moniker the Angel of Death as he systematically murdered dozens of vulnerable patients under the guise of providing compassionate care. A case that remains one of the most extensive and disturbing examples of institutional serial murder in American medical history. Born on August 15, 1952, in Butler County, Ohio, Harvey grew up in a deeply troubled household characterized by severe physical abuse at the hands of his father and emotional neglect that left him with profound psychological scars and a deeply distorted sense of empathy, and his childhood was further marred by episodes of extreme cruelty toward animals. A well-documented behavioral red flag that psychologists and criminal profilers have long associated with the development of antisocial and psychopathic personality traits. Harvey's entry into the healthcare system began in the early 1970s when he took a job as a nurse's aide at the Drake Memorial Hospital in Cincinnati, Ohio, a position that gave him direct access to elderly, chronically ill, and otherwise medically vulnerable patients who were largely unable to advocate for themselves or communicate effectively about their care, making them ideal targets for a predator seeking to inflict harm under the cover of medical legitimacy. Harvey's killing methods were remarkably varied and evolved significantly over the years, demonstrating a disturbing creativity and adaptability in his approach to murder, and he used virtually any means available to him in the hospital environment to end the lives of his patients, including injecting lethal doses of insulin, heparin, and potassium chloride directly into intravenous lines, poisoning food and beverages with arsenic and cyanide, suffocating patients with plastic bags or pillows, and in some cases, deliberately turning off patients' life support equipment or tampering with their oxygen supplies. In later interviews and confessions, Harvey offered varying and often contradictory explanations for his motives, at times claiming that he was acting out of a twisted sense of mercy by euthanizing patients he believed were suffering, while at other times admitting that he killed simply because he enjoyed the feeling of power and control it gave him, and he also acknowledged that some of his victims were murdered because they had annoyed him or because he was angry at another staff member and wanted to create problems for them. The true scale of Harvey's killing spree is staggering, as he ultimately confessed to murdering approximately 70 patients between 1970 and 1987, though some investigators and experts believe the actual number could be significantly higher, given that many of his victims were elderly or terminally ill patients whose deaths would not typically trigger investigations or autopsies, and Harvey himself admitted that he lost count of the exact number of people he killed. Harvey's ability to operate undetected for so long was facilitated by a healthcare system that was ill-equipped to identify and respond to the warning signs of a predatory employee, as the hospitals and nursing facilities where he worked suffered from inadequate supervision, poor record-keeping, and a cultural reluctance to question the actions of seemingly dedicated and hard-working staff members, particularly those willing to take on the difficult and unpleasant tasks that other employees avoided. The beginning of the end for Harvey came in 1987 when he was working at the Marymount Hospital in London, Kentucky, and a fellow employee witnessed him acting suspiciously near a patient's room, prompting an internal investigation that led to the discovery of cyanide and other toxic substances in Harvey's possession, as well as evidence that he had been tampering with patients' medications and food. When confronted by investigators, Harvey initially attempted to downplay his actions, but as the evidence mounted and authorities began reviewing death records from his previous places of employment, the full scope of his murderous career began to emerge, and he eventually began confessing, leading detectives on a grim journey through years of unsolved deaths at hospitals across Ohio and Kentucky. The legal proceedings against Harvey were conducted in multiple jurisdictions, as his crimes spanned several states and numerous counties, and in order to avoid the death penalty, Harvey agreed to cooperate with investigators and plead guilty to multiple counts of murder, providing detailed confessions that helped authorities formally close dozens of previously unexplained deaths. In 1987, Harvey pleaded guilty to 37 murders in Kentucky and was sentenced to multiple consecutive life terms in prison, and in subsequent proceedings in Ohio, he pleaded guilty to additional murders, receiving further life sentences that guaranteed he would never be released from custody. The trial and subsequent investigations revealed horrifying details about Harvey's methods and his complete lack of remorse for his actions, as he described in cold and matter-of-fact terms how he would approach a patient's bed in the middle of the night, administer a lethal dose of poison or suffocate them, and then simply walk away and return to his normal duties as if nothing had happened. The impact of Harvey's crimes on the families of his victims was devastating, as many relatives who had believed their loved ones died natural deaths were forced to confront the horrifying reality that their family members had been deliberately murdered by a trusted caregiver, and the resulting grief, anger, and sense of betrayal led to numerous civil lawsuits against the hospitals and nursing facilities that had employed Harvey and failed to protect their patients. The broader implications of the Donald Harvey case forced a significant reckoning within the healthcare industry, as hospitals and nursing homes across the country were compelled to reevaluate their hiring practices, employee supervision protocols, and systems for monitoring and reporting suspicious patient deaths, and the case became a foundational reference point in the development of policies designed to detect and prevent healthcare serial murder. Donald Harvey spent the remainder of his life in prison, serving his sentences at the Kentucky State Reformatory in LaGrange, Kentucky, and on March 30, 2017, he was found severely beaten in his cell by another inmate and died from his injuries the following day, bringing an abrupt and violent end to the life of one of the most prolific serial killers in American medical history. His death in prison was met with little sympathy from the families of his victims or the public, who viewed it as a form of rough justice for a man who had shown absolutely no mercy to the dozens of vulnerable people he murdered over nearly 2 decades. And the Harvey case continues to serve as a stark reminder of the catastrophic consequences that can occur when healthcare institutions fail to recognize and respond to the presence of a predatory individual operating within their walls. Number 4, Niels Hogel, a German nurse convicted of murdering dozens of patients in 2 hospitals in northwestern Germany, whose case sent shockwaves through the entire German healthcare system and is widely considered to be one of the worst serial killing cases in post-war European history, revealing stunning systemic failures that allowed a remorseless killer to murder with impunity for years. Born on December 30, 1976, in Wilhelmshaven, a port city in Lower Saxony, Germany, Hogel grew up in what appeared to be an unremarkable middle-class household, though later psychological assessments would reveal deep-seated emotional disturbances, a profound need for recognition, and a personality structured around manipulation and deceit that he skillfully concealed behind a friendly and competent professional facade during his nursing career. Hogel began working as a nurse in 1999 at the Oldenburg Clinic, a major hospital in the city of Oldenburg in Lower Saxony, where he was assigned to the intensive care unit, an environment that provided him with direct access to critically ill patients who were connected to life support systems, intravenous medication lines, and monitoring equipment, all of which he would eventually weaponize to carry out his lethal acts. Hogel's method of killing was chilling in its simplicity and clinical efficiency, as he would inject his patients with overdoses of cardiovascular medications, primarily gileurypmal, the brand name for Ajmalin, an antiarrhythmic drug that in excessive doses causes severe cardiac disturbances including ventricular fibrillation and cardiac arrest, and he would then wait for the patient to go into crisis before calling for other medical staff, positioning himself as the first responder in a desperate resuscitation effort that he had himself orchestrated. The motivation that drove Hogel to murder was not financial gain, mercy, or revenge but rather an almost incomprehensible desire for the adrenaline rush and social validation that came from being at the center of a high-stakes medical emergency, as he later admitted to investigators that he enjoyed the excitement of attempting to resuscitate patients and craved the praise and recognition he received from colleagues and supervisors when he participated in dramatic emergency interventions, even though he was the one who had caused the crisis in the first place. Between 1999 and 2005, Hogel worked at the Oldenburg Clinic, and during this period, an unusually high number of patients suffered unexplained cardiac arrests and deaths, particularly during shifts when Hogel was on duty, yet despite statistical anomalies that should have raised serious alarms, the hospital's management and medical staff failed to connect the dots, attributing the deaths to the severity of the patient's underlying conditions rather than to deliberate foul play. In 2005, Hogel left the Oldenburg Clinic and took a position at the Delmenhorst Clinic, another hospital in Lower Saxony, and the pattern of suspicious cardiac arrests and deaths immediately resumed during his shifts, with the statistical spike in patient emergencies correlating so precisely with Hogel's work schedule that it later became one of the most compelling pieces of circumstantial evidence against him. The breakthrough in the case came in 2005 when a colleague at the Delmenhorst Clinic caught Hogel in the act of injecting a patient with an unauthorized medication, prompting an immediate internal investigation that led to the discovery of missing medication vials and a trail of suspicious patient incidents, and when police were called in, they began the painstaking process of reviewing hundreds of patient records and death certificates from both the Delmenhorst and Oldenburg clinics. The criminal investigation into Hogel's activities was unprecedented in its scope and complexity, as authorities exhumed the bodies of dozens of patients who had died under his care and conducted toxicological analyses to determine whether they had been administered lethal doses of unauthorized medications, and the results were devastating, confirming that a significant number of the exhumed bodies contained traces of medications that should never have been in their systems. Hogel was arrested in 2008 and initially charged with a limited number of murders, as the investigation was still ongoing and the full scale of his crimes had not yet been established, and in 2011, he was convicted of 2 murders and 2 attempted murders at the Delmenhorst Clinic and sentenced to life imprisonment, a verdict that, while significant, represented only a fraction of the deaths he was suspected of causing. Following his initial conviction, authorities launched a massive expanded investigation that involved reviewing the records of every patient who had died or suffered cardiac arrest during Hogel's shifts at both hospitals over a period of several years, a review that ultimately identified over 300 suspicious cases, of which at least 106 were determined to be homicides attributable to Hogel with a high degree of certainty based on medical evidence, statistical analysis, and patient records. In a second trial that began in 2017, Hogel faced charges for an additional 97 murders, and the proceedings were emotionally grueling as the families of the victims filled the courtroom to hear the horrifying details of how their loved ones had been deliberately killed by a nurse they had trusted to care for them, and the sheer volume of the charges made the trial one of the largest and most complex murder cases in German legal history. On June 6, 2019, Hogel was convicted of 85 additional murders and sentenced to life imprisonment, bringing his total confirmed murder count to 87, though investigators have stated publicly that the true number of his victims could exceed 100 and may never be fully known because some potential victims were cremated before evidence could be preserved. The judge in the case described Hogel's actions as beyond comprehension and characterized him as a killer who had exploited the absolute vulnerability of his patients in the most cynical and selfish manner imaginable, driven by nothing more than a desire for personal excitement and the ego gratification of being seen as a skilled resuscitator. The aftermath of the Hogel case precipitated a national crisis of confidence in the German healthcare system, as it became clear that multiple hospitals had ignored or failed to act on clear warning signs, including the statistical impossibility of the concentration of patient deaths during Hogel's shifts, and the case led to sweeping reforms in hospital monitoring, medication security, and whistleblower protections throughout Germany. Several hospital administrators and physicians who had been aware of the suspicious patterns during Hogel's employment but failed to take decisive action were subsequently investigated, disciplined, or prosecuted for their roles in enabling his killing spree, and the case became the subject of intense national debate about institutional accountability and the moral obligations of healthcare professionals to protect their patients from predatory colleagues. Niels Hogel is currently serving his life sentence in a German prison, and his case stands as the definitive example in modern European history of how a single healthcare worker, operating within a system that failed at every level to identify and stop him, can cause death on a scale that rivals some of the worst serial killers in history, leaving behind a legacy of destroyed families and a healthcare system forever changed by the knowledge of what was allowed to happen within its walls. Number 5, Orville Lynn Majors, a licensed practical nurse working at Vermilion County Hospital in Clinton, Indiana, during the mid-1990s, who was convicted of murdering 6 patients by injecting them with lethal doses of potassium chloride, a crime spree that terrified a small rural community and exposed devastating flaws in how hospitals handle suspicions of internal murder. Born in 1961 in Linton, Indiana, Majors grew up in a working-class family in the rural heartland of the American Midwest, and by most accounts, his early life was unremarkable, though those who knew him well in adulthood described him as a strange and socially awkward individual who exhibited an unusual fascination with death and dying that extended beyond what would be considered normal professional curiosity for someone working in a medical environment. Majors obtained his licensed practical nurse certification and eventually secured a position at Vermilion County Hospital, a small community hospital that served the rural population of Vermilion County and surrounding areas, a setting where patients tended to know their healthcare providers personally and where the level of trust between medical staff and the community was exceptionally high, a trust that Majors would ultimately exploit in the most horrific way imaginable. Beginning in approximately 1993 and continuing through 1995, an alarming pattern began to emerge at Vermilion County Hospital as patients who had been admitted for relatively minor or manageable conditions suddenly began dying unexpected deaths, and the common thread connecting these deaths was that they overwhelmingly occurred during shifts when Majors was assigned to the intensive care unit or was otherwise responsible for monitoring the patients. Majors' weapon of choice was potassium chloride, a salt compound that is naturally present in the human body and is routinely used in medical settings in carefully controlled doses to treat hypokalemia, or low potassium levels, but when administered in excessive amounts, potassium chloride causes immediate and catastrophic cardiac arrest by disrupting the electrical signaling system of the heart. And because potassium is a naturally occurring substance that degrades quickly after death, it is extraordinarily difficult to detect in post-mortem toxicology, making it an almost ideal murder weapon for someone with medical knowledge and access to hospital medication supplies. The death rate at Vermilion County Hospital during Majors' tenure was statistically astronomical compared to what would be expected for a facility of its size and patient population, with some analyses indicating that the mortality rate on Majors' shifts was hundreds of times higher than on shifts staffed by other nurses, a discrepancy so extreme that it defied any plausible medical explanation and pointed overwhelmingly toward deliberate foul play. Despite the glaring statistical evidence, the hospital's response was frustratingly slow and inadequate, as administrators initially attributed the spike in deaths to a coincidental cluster of critically ill patients or seasonal variations in patient acuity, and it was not until a group of courageous nurses within the hospital began documenting the suspicious pattern and pressing management to take action that a formal investigation was finally initiated. These nurses, who risked their own careers and faced significant pushback from hospital leadership, meticulously compiled records showing that patient deaths correlated almost perfectly with Majors' work schedule, and they also reported witnessing Majors acting suspiciously near patient rooms, including being present in areas where he had no assigned duties at the precise times that patients went into cardiac arrest. The nursing staff's persistence eventually forced the hospital to alert law enforcement, and the Indiana State Police launched a criminal investigation that included reviewing hundreds of patient records, conducting exhumations and autopsies on patients who had been buried without suspicion, and interviewing dozens of current and former hospital employees about their observations and experiences working alongside Majors. During the investigation, authorities learned that Majors had a deeply troubling habit of making statements about patients being ready to die or suggesting that certain patients would be better off dead, comments that took on a far more sinister meaning in light of the evidence linking him to the suspicious deaths, and several colleagues also reported that Majors had an unusual and inappropriate interest in the resuscitation process, frequently positioning himself at the center of emergency response efforts when patients coded. Majors was formally charged in 1997 with 6 counts of murder, and the trial that followed was a landmark case in the emerging field of healthcare serial murder prosecution, as the prosecution relied heavily on statistical evidence and pattern analysis rather than direct physical evidence like eyewitness testimony or recovered murder weapons. A legal strategy that was relatively novel at the time but has since become more common in cases where a medical professional is suspected of serial murder. The prosecution presented compelling expert testimony from statisticians who demonstrated that the probability of the death spike occurring by chance during Majors's shifts was astronomically low, essentially approaching mathematical impossibility. And medical experts testified about the pharmacological effects of potassium chloride and how the symptoms exhibited by the victims were consistent with potassium-induced cardiac arrest rather than natural deterioration. The defense attempted to discredit the statistical evidence and argued that the deaths could be explained by the patient's underlying medical conditions and the inherent risks associated with intensive care treatment, but the jury found the prosecution's case overwhelming, and on October 26, 1999, Orville Lynn Majors was convicted of 6 murders and sentenced to 360 years in prison. The verdict was met with relief and a measure of closure by the families of the victims, though many in the community believed that Majors had killed far more than 6 people and that the true scope of his crimes would never be fully known because of the limitations of the evidence and the decision by prosecutors to focus on the strongest cases rather than attempting to pursue every suspicious death. The broader implications of the Majors case were significant for the healthcare industry, particularly for small community hospitals that may not have the resources or expertise to detect the subtle patterns that indicate a healthcare worker is murdering patients, and the case highlighted the critical importance of listening to frontline nursing staff when they raise concerns about suspicious activities, as it was ultimately the persistence and bravery of the nurses at Vermilion County Hospital that brought Majors to justice. In the aftermath of the case, multiple civil lawsuits were filed against the hospital by the families of Majors's victims, alleging that the institution had been negligent in failing to investigate and stop the killings sooner, and the case also contributed to a growing national awareness of the phenomenon of healthcare serial murder and the need for more robust detection and prevention systems in medical facilities across the country. Orville Lynn Majors remains incarcerated in the Indiana Department of Correction, serving his 360-year sentence, and his case continues to be cited by patient safety advocates and criminologists as a textbook example of how statistical anomalies, when properly identified and investigated, can be used to bring a serial killer to justice even in the absence of traditional forensic evidence, while also serving as a sobering reminder of the devastating consequences that occur when institutions fail to act on the warnings provided by their own employees. Number 6. Beverly Allitt, a British pediatric nurse who carried out a series of attacks on children in her care at Grantham and Kesteven Hospital in Lincolnshire, England, in 1991, murdering 4 children and attempting to kill 9 others over a period of just 59 days. A rampage of violence against the most vulnerable patients imaginable that earned her the infamous nickname the Angel of Death in the British press and shocked the nation to its core. Born on October 4, 1968, in Corby Glen, a small village in Lincolnshire, Allitt had a deeply troubled childhood and adolescence marked by a series of mysterious and unexplained physical ailments that required frequent hospitalizations, leading some psychologists who later studied her case to suggest that she suffered from Munchausen syndrome, a psychiatric disorder in which a person fakes or induces illness in themselves to gain attention and sympathy, a diagnosis that would take on a far more sinister dimension when considered alongside her later crimes. Allitt's transition from a patient who sought attention through self-harm to a nurse who inflicted harm on others to satisfy her psychological needs followed a trajectory that criminal profilers have since recognized as a known risk pathway, as individuals with factitious disorders who enter healthcare professions sometimes escalate from harming themselves to harming patients, a phenomenon known as Munchausen syndrome by proxy, though the precise psychiatric classification of Allitt's motivations remains a subject of debate among experts. After completing her nursing training, Allitt secured a position as a pediatric nurse on the children's ward at Grantham and Kesteven Hospital, a relatively small district general hospital that served the local community, and she began working there in 1991, just a few months before her killing spree began, during a period when the hospital was experiencing staffing shortages that required her to work extended shifts with relatively limited supervision. Allitt's attacks on her young patients were characterized by a disturbing variety of methods and a level of violence that seemed designed to cause maximum suffering and medical crisis, as she used insulin injections to cause life-threatening hypoglycemia, administered air injections into intravenous lines to cause embolisms that could lead to sudden cardiac arrest, and in some cases, physically assaulted children by suffocating them or causing other forms of direct harm. The first victim was 7-week-old Liam Taylor, who was admitted to the ward in February 1991 for a chest infection and died suddenly after going into cardiac arrest, a death that was initially attributed to his underlying medical condition, and over the following weeks, the attacks continued with horrifying regularity as infant after infant and toddler after toddler experienced unexplained cardiac arrests, breathing difficulties, and seizures while in Alit's care. Among the most tragic of Alit's victims was 11-month-old Becky Phillips, who was admitted to the hospital for a mild case of gastroenteritis and was subjected to a massive insulin overdose by Alit that caused severe brain damage, and though Becky was transferred to a larger hospital for specialist treatment, she died 2 days later from the irreversible damage inflicted by the overdose, a death that her parents were initially told was a complication of her illness rather than a deliberate act of murder. Another victim, 15-month-old Katie Mae Phillips, Becky's older sister, was admitted to the same ward several weeks later out of her parents' desperate desire to understand what had happened to Becky, and Alit attacked Katie as well, injecting her with insulin and causing catastrophic harm, though remarkably, Katie survived the attack with permanent disabilities that have affected her for the rest of her life. The mounting death toll and the inexplicable cluster of medical emergencies on the children's ward eventually prompted hospital officials to call in external consultants and begin a serious review of the cases, and it was the recognition by a senior pediatrician that the pattern of incidents correlated with Alit's shifts that finally led to the identification of a suspect and the initiation of a criminal investigation. When police were called in, they discovered that the common thread in virtually every case was the presence of Beverly Alit, and a painstaking review of medication records, patient charts, and staffing schedules revealed that Alit had been present for every single suspicious incident and had been the last person to see each child before they went into crisis, evidence that formed the foundation of the prosecution's case. Alit was arrested in May 1991 and charged with multiple counts of murder and attempted murder, and during her interrogation, she denied any involvement in the attacks, maintaining her innocence despite the overwhelming circumstantial evidence linking her to the crimes, and her trial at Nottingham Crown Court in 1993 became one of the most closely watched criminal proceedings in British legal history. The prosecution presented a meticulous case built on medical evidence showing that the children had been poisoned with insulin or subjected to air embolisms, expert testimony establishing that these interventions could not have occurred accidentally and must have been deliberately administered by someone with medical training and access to the patients, and the damning statistical correlation between Alit's shifts and the attacks. Alit's defense team attempted to argue that the evidence was circumstantial and that the deaths and injuries could be attributed to natural causes or complications of the children's underlying conditions, but the jury rejected these arguments, and on May 23, 1993, Alit was convicted of 4 murders, 7 attempted murders, and 6 counts of causing grievous bodily harm, receiving 13 life sentences with a recommended minimum term of 30 years, though this was later increased to 40 years by the High Court. The case prompted a massive public inquiry and led to sweeping changes in the way the National Health Service screens, monitors, and supervises healthcare workers, particularly those working with vulnerable populations like children and the elderly, and it exposed serious deficiencies in the systems that had allowed Alit to be hired and to continue working despite evidence that she had a history of psychological problems that should have raised red flags during the recruitment process. The impact on the families of Alit's victims was profound and enduring, as parents who had entrusted their children to a hospital they believed was safe were forced to come to terms with the fact that their children had been deliberately and brutally attacked by a nurse who was supposed to protect them, and several families became outspoken advocates for improved patient safety measures in the British healthcare system. Beverly Alit remains imprisoned in a high-security facility in England, and her case continues to be studied by criminal psychologists and healthcare safety experts as a prime example of how factitious disorders can escalate into lethal violence when the individual gains access to vulnerable patients, and it stands as one of the most disturbing cases of medical serial murder in British criminal history, a case that shattered the illusion of safety in pediatric healthcare and forced an entire nation to confront the horrifying reality that not everyone who wears a nurse's uniform does so with healing in their heart. Number 7, Efren Saldivar, a respiratory therapist at Glendale Adventist Medical Center in Glendale, California, who confessed to murdering as many as 50 patients by injecting them with lethal doses of muscle-paralyzing drugs over a period of nearly a decade, making him one of the most prolific healthcare serial killers in California history and exposing catastrophic security failures in one of the state's major medical centers. Born in 1969, Saldivar grew up in the Los Angeles area and entered the healthcare field as a respiratory therapist, a specialized medical professional responsible for managing patients on mechanical ventilators, administering breathing treatments, and monitoring respiratory function in critically ill patients, a role that provided him with direct access to life support equipment and dangerous medications that he would ultimately use as instruments of murder. Saldivar began working at Glendale Adventist Medical Center in the late 1980s, and over the following decade, he became known among his colleagues as a quiet and unassuming employee who was willing to work unpopular shifts, including night shifts and holidays, a work ethic that initially earned him praise from supervisors but would later be recognized as a calculated strategy that allowed him to operate with minimal oversight during the hours when patient monitoring was at its weakest. Saldivar's method of killing was to inject patients with succinylcholine, also known as SUX, a powerful neuromuscular blocking agent that paralyzes all voluntary muscles in the body, including the diaphragm, effectively stopping the patient's ability to breathe while leaving them fully conscious and aware, a horrifying form of death that has been described by medical experts as one of the most agonizing ways a human being can die, as the victim remains mentally alert but completely unable to move or communicate their distress as they slowly suffocate. Because succinylcholine metabolizes very rapidly in the body and breaks down into compounds that are naturally present in human tissue, it is virtually undetectable in standard toxicology screenings, making it an extremely effective murder weapon for someone with medical knowledge and access. And Saldivar exploited this pharmacological characteristic to kill patients over a period of years without triggering the autopsies or investigations that might have exposed his crimes earlier. The turning point in the Saldivar investigation came in 1997 when hospital administrators noticed an unusually high number of patient deaths in the respiratory care unit, particularly during shifts when Saldivar was working, and a preliminary internal review revealed a statistical anomaly so extreme that it could not be explained by patient acuity or any other legitimate medical factor, prompting the hospital to contact the Glendale Police Department. When detectives began investigating, they quickly discovered that Saldivar had been the last person to attend to many of the patients who had died under suspicious circumstances, and they also learned that medication supplies of succinylcholine and other paralytic agents in the respiratory care unit showed unexplained discrepancies, with far more medication being dispensed than could be accounted for by legitimate patient care. In March 1998, Saldivar was called in for questioning by police, and in a stunning and unexpected development, he confessed to murdering approximately 50 patients over the previous 8 years, providing investigators with a detailed account of how he would select his victims, prepare the lethal injections, and administer the drugs to patients who were typically elderly, critically ill, and unable to defend themselves. However, the legal situation became extraordinarily complicated when Saldivar recanted his confession just days after giving it, claiming that he had been coerced by detectives and that he had not actually murdered anyone, creating a massive legal and evidentiary challenge for prosecutors who now had a confession but no physical evidence linking Saldivar to specific murders because the bodies of the victims had been buried or cremated years earlier without toxicological testing. The lack of physical evidence meant that prosecutors could not pursue murder charges for the vast majority of the deaths Saldivar had confessed to, and they were forced to focus their case on a small number of incidents where additional circumstantial evidence or witness testimony could be used to support the charges. A devastating limitation that meant dozens of families would never see justice for the murder of their loved ones. In 2002, Saldivar pleaded guilty to 6 counts of murder as part of a plea agreement that spared him the death penalty, and he was sentenced to 6 consecutive life terms in prison without the possibility of parole, a sentence that, while substantial, represented only a fraction of the killings he had confessed to committing. During the sentencing hearing, family members of the victims delivered emotional impact statements describing the anguish of learning that their loved ones had been murdered rather than dying natural deaths, and many expressed their fury that Saldivar would never face justice for the full scope of his crimes because of the evidentiary gaps created by the failure to investigate the suspicious deaths when they first occurred. The broader implications of the Saldivar case were far-reaching and led to significant reforms in how California hospitals manage and monitor controlled substances, particularly paralytic agents like succinylcholine that have no legitimate use outside of specific medical procedures and that can be easily weaponized by someone with medical training. The case also highlighted the critical importance of conducting autopsies or at minimum thorough death reviews when patients die unexpectedly in hospital settings, as the failure to perform autopsies on Saldivar's victims at the time of their deaths meant that the window for collecting physical evidence closed permanently, allowing a serial killer to escape full accountability for his crimes. Efrain Saldivar is currently serving his life sentences in a California prison, and his case remains one of the most frustrating and disturbing examples in the annals of healthcare serial murder, a case in which a killer confessed to an enormous number of murders but was held legally accountable for only a small fraction of them due to systemic failures in death investigation and evidence preservation, leaving the families of dozens of victims without the closure of a full legal reckoning and serving as a permanent reminder of the costs of institutional complacency in the face of inexplicable patient deaths. Number 8, Robert Rubalcava, a licensed vocational nurse working at Memorial Medical Center in Modesto, California, who was convicted of murdering 3 elderly patients by administering lethal overdoses of morphine, a case that exposed the vulnerability of elderly patients in long-term care settings and demonstrated how a healthcare serial killer can exploit the inherent ambiguity of end-of-life care to conceal deliberate murder. Born in 1964, Rubalcava worked as a licensed vocational nurse, a position that placed him in direct contact with elderly and chronically ill patients who required ongoing medical care and medication management, and he was assigned to the subacute care unit at Memorial Medical Center, a ward that housed some of the most vulnerable patients in the facility, including elderly individuals with severe cognitive impairments, terminal illnesses, and limited ability to communicate or advocate for themselves. Rubalcava's crimes came to light in 2008 when a sharp-eyed pharmacist at the hospital noticed discrepancies in the medication administration records for morphine, a powerful opioid painkiller that is tightly controlled because of its potential for abuse and its capacity to cause fatal respiratory depression in excessive doses. And the pharmacist's review revealed that significantly more morphine had been removed from the medication dispensing system than was accounted for by the documented patient doses, a discrepancy that pointed to unauthorized use of the drug. When hospital security and administrators began investigating the morphine discrepancy, they identified Rubalcava as the employee who had withdrawn the unaccounted-for medication, and a concurrent review of patient deaths in the subacute unit revealed that 3 elderly patients had died unexpectedly during shifts when Rubalcava was on duty, all within a relatively short period of time and all under circumstances that were inconsistent with their documented medical conditions. The 3 victims were Josephine Story, who died in October 2007 at the age of 81, Margaret Kelly, who died in November 2007 at the age of 94, and Dorothy Anderson, who died in January 2008 at the age of 91. And all 3 women had been residents of the subacute care unit who were receiving care for chronic age-related conditions but were not considered to be in immediate danger of death at the time of their demise. The Modesto Police Department was called in to investigate, and detectives quickly focused on Rubalcava after the hospital's internal investigation identified him as the common factor in all 3 deaths and the person responsible for the morphine discrepancies, and when they interviewed Rubalcava, they found his explanations for the missing medication to be evasive and inconsistent, further heightening their suspicions. Because the 3 victims had already been buried, the investigation relied heavily on circumstantial evidence, including the medication dispensing records showing that Rubalcava had withdrawn morphine at or near the times of each patient's death, the statistical anomaly of 3 deaths occurring during his shifts in a short period, and testimony from other nursing staff members who stated that the patients had not been in acute distress or near death before Rubalcava administered the morphine doses that killed them. Rubalcava was arrested and charged with 3 counts of murder, and the prosecution's case centered on demonstrating that the morphine overdoses were not accidental medication errors but deliberate acts of murder, presenting evidence that Rubalcava had administered doses far exceeding any legitimate therapeutic range and had failed to document the administrations properly, behavior consistent with someone trying to conceal their actions rather than making an honest mistake. The trial revealed that Rubalcava had a history of substance abuse and had previously been disciplined for medication-related issues, information that the prosecution used to establish a pattern of irresponsible and deceptive behavior with controlled substances, Though the defense argued that his prior issues did not prove that he had deliberately murdered anyone and that the deaths could have been the result of the patient's fragile medical conditions. On March 7, 2013, Robert Rubalcava was convicted of 3 counts of second-degree murder and was subsequently sentenced to 78 years to life in prison, a sentence that reflected the court's determination that he had deliberately exploited the vulnerability of elderly patients in his care to satisfy some dark personal compulsion that he never fully explained to investigators or the court. The Rubalcava case had significant implications for the long-term care industry in California and beyond, as it underscored the particular vulnerability of elderly patients in subacute and skilled nursing facilities, where high patient-to-staff ratios, cognitive impairment among residents, and the inherent ambiguity of end-of-life decline create conditions that a predatory healthcare worker can exploit with relative ease. In the aftermath of the case, Memorial Medical Center implemented enhanced medication monitoring systems, including more rigorous tracking of controlled substance dispensing and automated alerts that flag unusual patterns of medication withdrawal, and the case also contributed to broader regulatory discussions about the need for stronger oversight of licensed vocational nurses and other frontline healthcare workers who have access to dangerous medications but may operate with less direct supervision than registered nurses or physicians. The families of Rubalcava's victims expressed a mixture of relief that he had been brought to justice and profound grief that their loved ones had been deliberately killed in a place that was supposed to be safe, and several family members spoke publicly about the guilt they felt for not having been present to protect their elderly relatives from a killer who was supposed to be caring for them. Robert Rubalcava remains incarcerated in the California prison system, and his case serves as a grim reminder that healthcare serial murder is not confined to large intensive care units in major urban hospitals but can occur in any setting where vulnerable patients are entrusted to the care of individuals who are willing to exploit that trust for the most malicious of purposes. Number 9. Vicki Dawn Jackson, a licensed vocational nurse at Nocona General Hospital, a small rural hospital in Nocona, Texas, who was convicted of murdering 4 patients by injecting them with lethal doses of the muscle paralytic succinylcholine between December 2000 and December 2001, a killing spree that terrorized a tiny Texas community and exposed the unique vulnerabilities of small rural hospitals to predatory healthcare workers. Born in 1966, Jackson was a lifelong resident of the Nocona area, a tight-knit rural community in northern Texas where everyone knew everyone else, and the local hospital served as a cornerstone of the community's healthcare infrastructure, providing essential medical services to a population that relied almost entirely on this single small facility for their medical needs. Jackson had worked at Nocona General Hospital for several years and was considered a competent and reliable nurse by her supervisors, though some colleagues would later recall that she had an unusual interest in death and dying and occasionally made comments that, in retrospect, seemed to foreshadow the horrors she would eventually inflict on her patients. The first suspicious death occurred in December 2000 when 78-year-old Otis Bean, a patient admitted to the hospital for treatment of pneumonia, suddenly went into cardiac arrest and died despite resuscitation efforts, and over the following 12 months, 3 more patients died under similarly mysterious circumstances, all of them elderly and all experiencing sudden, unexplained cardiac arrests that defied medical explanation given their relatively stable conditions prior to the events. The victims were 74-year-old Letty DeLuna, who died in February 2001, 84-year-old James Emberson, who died in September 2001, and 92-year-old Elva Doris White, who died in December 2001, and in each case, the patients had been in the hospital for treatable conditions and were not considered to be at imminent risk of death before they suddenly coded and could not be revived. The critical breakthrough in the case came when a new director of nursing, who had recently joined the hospital from a larger facility with more sophisticated monitoring systems, began reviewing patient records and noticed that the 4 deaths had all occurred during shifts when Jackson was the nurse on duty, and that in each case, Jackson had been the last person to document providing care to the patient before they went into cardiac arrest. When the director of nursing brought her concerns to the hospital administrator, an internal investigation was launched that included a review of medication records, which revealed that vials of succinylcholine, a paralytic agent that was rarely used in the small hospital and should have shown minimal dispensing activity, had been withdrawn from the pharmacy in quantities that far exceeded any legitimate clinical need. The hospital contacted the Texas Department of State Health Services and local law enforcement, and when investigators examined the medication dispensing records in detail, they found that Jackson had been withdrawing succinylcholine from the pharmacy on or near the dates of each of the 4 deaths, creating a clear evidentiary link between her access to the murder weapon and the timing of the murders. Jackson was arrested in 2002 and charged with 4 counts of capital murder, and the prosecution's case relied on the combination of the medication records, the statistical correlation between her shifts and the deaths, and testimony from medical experts who explained the pharmacological effects of succinylcholine and how the symptoms exhibited by each victim were consistent with paralysis-induced respiratory arrest rather than natural cardiac events. During the trial, the prosecution presented evidence that Jackson had been experiencing significant personal difficulties at the time of the murders, including financial problems and relationship issues, but they did not identify a clear and specific motive for the killings, leading to speculation that Jackson may have been acting out of a generalized psychological compulsion or a need for the excitement and drama of participating in resuscitation attempts, similar to the motivations identified in other healthcare serial killer cases. The defense argued that the evidence was circumstantial and that the deaths could be attributed to the patient's advanced age and underlying medical conditions, but the jury found the circumstantial evidence overwhelmingly compelling, particularly the medication records that placed Jackson in possession of a lethal drug at the precise times her patients were dying. In 2004, Vicki Dawn Jackson was convicted of 4 counts of capital murder and sentenced to life in prison without the possibility of parole, and the judge in the case commented on the extraordinary betrayal of trust represented by Jackson's crimes, noting that she had violated the most fundamental obligation of a healthcare professional by turning her skills against the very people she was sworn to protect. The impact of Jackson's crimes on the Nocona community was profound and lasting, as the small town was forced to confront the reality that a serial killer had operated in their local hospital, a place that was supposed to represent healing and safety, and many residents expressed deep and lingering fear about seeking medical treatment at the facility where the murders had occurred. The case also had significant operational consequences for Nocona General Hospital, which faced intense scrutiny from state regulators and the media, and the hospital was eventually forced to implement major changes to its medication security protocols, employee monitoring systems, and death investigation procedures to prevent a similar tragedy from occurring in the future. Vicki Dawn Jackson remains incarcerated in a Texas prison, and her case is frequently cited by patient safety experts as an example of how small rural hospitals, which often lack the resources and sophisticated monitoring systems of larger urban medical centers, can be particularly vulnerable to healthcare serial killers who exploit the limited oversight and close-knit trust that characterize these institutions, a vulnerability that demands targeted safeguards and vigilance to protect the most defenseless members of rural communities from predators hiding behind the mask of medical professionalism. Number 10, Colin Norris, a Scottish nurse who was convicted in 2008 of murdering 4 elderly patients and attempting to murder a 5th at 2 hospitals in Leeds, England, by administering lethal doses of insulin, a case that generated significant controversy in the British medical and legal communities because of questions about the reliability of the evidence used to secure his convictions. Born in 1976 in Glasgow, Scotland, Norris trained as a nurse and began his career working in elderly care wards at St James's University Hospital and the Leeds General Infirmary in Leeds, England, facilities that served a large elderly patient population requiring complex medical care and frequent medication management. Between 2002 and 2004, 5 elderly patients under Norris's care suffered sudden and severe episodes of hypoglycemia, a dangerous condition in which blood sugar drops to life-threatening levels, causing confusion, loss of consciousness, seizures, and potentially death, and in 4 of the 5 cases, the patients died despite emergency medical intervention. The victims were 80-year-old Ethel Hall, who died in 2002, 79-year-old Doris Ludlam, who died in 2002, 88-year-old Irene Crooks, who died in 2002, and 76-year-old Bridget Burke, who died in 2002, and a 5th patient, 90-year-old Vera McBride, survived a hypoglycemic episode in 2004. And all 5 women were patients who had been admitted to the hospitals for conditions that did not involve diabetes or any other medical issue that would have explained the sudden drops in their blood sugar levels. The investigation into the hypoglycemic episodes began after hospital staff noticed that the incidents correlated with Norris's shifts and that the patients involved were not diabetic and had no medical reason to experience spontaneous hypoglycemic events, and blood tests confirmed that the patients had been administered insulin, a hormone that lowers blood sugar and is used to treat diabetes but is extremely dangerous when given to non-diabetic patients in uncontrolled doses. Norris was arrested in 2004 and charged with murder and attempted murder, and the prosecution's case at his trial in 2008 centered on the statistical correlation between his shifts and the hypoglycemic episodes, the absence of any legitimate medical explanation for the blood sugar drops, and testimony from medical experts who stated that the insulin could only have been administered deliberately by someone with access to the patients and knowledge of the drugs' effects. The defense argued that the evidence was entirely circumstantial and that natural causes or undiagnosed medical conditions could explain the hypoglycemic episodes, but the jury rejected these arguments, and on March 3, 2008, Cullen Norris was convicted of 4 murders and 1 attempted murder and sentenced to life imprisonment with a minimum term of 30 years. However, unlike the other cases in this compilation, the Norris case became the subject of intense and sustained controversy in the years following his conviction, as a growing number of medical experts, forensic scientists, and legal scholars raised serious concerns about the reliability of the evidence used to convict him, particularly the prosecution's reliance on statistical correlation and the testimony of medical experts who may have overstated the certainty with which they could conclude that the hypoglycemic episodes were caused by deliberate insulin administration rather than natural physiological processes. Critics of the conviction pointed to emerging medical research suggesting that elderly patients, particularly those who are frail, malnourished, or suffering from infections or liver dysfunction, can experience spontaneous hypoglycemic episodes without any external administration of insulin, a phenomenon that was not as well understood at the time of Norris's trial as it is today. And they argued that the prosecution's medical experts had presented an overly simplistic and scientifically uncertain analysis as established fact. In 2019, Norris's legal team submitted an appeal based on new medical evidence suggesting that spontaneous hypoglycemia in elderly patients was far more common than had been acknowledged at his trial, and in 2021, the Criminal Cases Review Commission, which investigates potential miscarriages of justice in England, referred Norris's case to the Court of Appeal for a full review. The case remains ongoing as of the most recent available information, and it has become a focal point in the broader debate about how healthcare serial murder cases are investigated and prosecuted, particularly the risks of relying too heavily on statistical evidence and incomplete medical science to secure convictions in cases where the physical evidence is ambiguous. Regardless of the ultimate legal outcome, the Cullen Norris case has had a profound impact on the British criminal justice system's approach to healthcare serial murder prosecutions, prompting a re-evaluation of the standards of medical evidence required in such cases and a greater willingness to consider alternative explanations for clusters of adverse medical events before concluding that they must be the result of deliberate foul play. The case also highlights the extraordinary difficulty of prosecuting healthcare serial murder cases, where the inherent ambiguity of medical outcomes, the limitations of forensic science, and the potential for cognitive bias among investigators and expert witnesses can combine to create a legal process that may not always arrive at the truth. A cautionary tale that sits in stark contrast to the other cases in this compilation where the evidence of guilt was clear and overwhelming, and it serves as a reminder that the pursuit of justice in healthcare murder cases must be guided by science and evidence rather than by the desire to find a convenient explanation for tragedies that may not have a simple resolution.